learning objectives for this presentation is to describe the presentation and diagnosis of varicose veins, which I'm sure all of you probably can do so, and also to outline the available treatment options for varicose veins, focusing on the minimally invasive treatments that's available. I must say most of those treatments have been around for quite some time, but maybe not marketed or made well known to people. So what are varicose veins? I wrote a very busy slide and I decided that that's probably not going to be very helpful. Maybe showing some pictures would be a little bit better, more useful and more entertaining. Most of you will see these varicose veins, either the big varix or the small spider veins on your nearly everyday practice probably. Yes? So the varicose veins are those that are greater than 3 millimeters in diameter. They normally have a tortuous and bulging appearance. And they can occur anywhere, basically, either in the front of the leg where the anterior accessory vein runs, or where the great saphenous vein runs, or it can be at the back of the knee where the small saphenous vein is. You've got these spider veins that you can see here. The picture next to that is the spider veins. And then you've got more varix there behind the knee. You've got these little reticular veins that you can see just in this picture down here. So they're about 1 to 3 millimeters, and they're not as tortuous, and they're also bluish in color. And the purple ones are the spider veins, only we call them purple ones. They're very small, they're less than 1 millimeter normally. So they normally have a similar pathophysiology process, although some of them can be related to either sun or aging, as you probably know. I'll go into the risk factors of varicose veins. This is quite commonly put up, with family history, genetic factors, more common in women, in pregnancies, people with increasing age, people with jobs with prolonged standing or sitting, any one of those. Activity is known to be protective. Pregnancies, I've mentioned before, and obesity, for some reason, in women, in obese women, varicose veins tend to happen more frequently than in obese men. I don't want to be boring and go through anatomy, which I think most of you will probably know, but just a little revision. So the anatomy of veins in the legs is basically very variable. I don't think we can identify two people with the same sort of anatomy because veins are so variable. So I like to think of it as an inverted tree trunk. So you've got all the superficial venous plexus going up, joining into a deep vein, which is the IVC, the biggest one. So we have the truncal axial veins. So there's two sets. The great saphenous vein, which is the one you can see here, the one in blue. It runs from the middle of the ankle to a hand's breadth at the knee, and then it joins into the saphenofemoral junction. And then you've got the deep vein in the front as well, which is the femoral vein. It comes from the popliteal to the femoral, and you've got other branches as well that joins in to the iliac veins. And then at the back of the knee, you've got the small saphenous vein, and it runs from the lateral of the ankle up into the saphenopopliteal junction where it joins behind the knee. Now, I wanted to bring up the perforating veins for two reasons. One is that they are very important because they help to drain all the superficial system into the deep network as well, and there's lots of them all along, especially around the knee. So the perforating veins also have valves in them, and they can become incompetent, and that can lead to big varices just where the perforating veins are. So you've got perforator incompetence, but no actual axial or truncal incompetence. The valves and the muscles are the important bits that you need to remember about the pathophysiology of venous disease. So presentation, again, most people would know all of this. 15 to 20% of people have visible varicose veins. That group would be the lucky group of people who can actually see the varicose veins. A lot of people have veins that you can't see, but they have aching and tiredness in your legs, and they complain of those symptoms. So those are the telltale signs that they may have venous disease if they complain of these sort of symptoms. So they get swelling sometimes, itching, that can be one, and pain and night cramps. I put up the venous eczema. This is one of the things that probably have not been spread around as much, I guess, as the other symptoms up there. So patients can present with a wide variety of itchy skin or red-brown stains on the legs, and that is a symptom of venous eczema. So when we get a duplex ultrasound on them, they have venous incompetence that we identify in the great saphenous vein. And after treating that, we notice that the brown staining and the venous eczema disappears. So the history of the is important for the patient assessment. So I like to go with a systematic approach. So a thorough medical history, basically specific to venous disease, clotting history, family history, the symptoms, onset and duration, the previous treatments, any venous complications including DVT, so that's quite important because that can lead to obviously incompetent valves. And in examination, the patient in general, so you look at them from head to toe, because if you're thinking about doing ultrasound-guided sclerotherapy, you want to make sure that they don't have patent foramen ovale or ASD. Check their pedal pulses because they're likely to go into class 2 compression. And of course, they have groins because they have had previous operations before. But the gold standard is to confirm that with a duplex examination. We know that with physical examination, we talk about the Trendelenburg and the Perthes test, but I don't think any of that is really very useful. So the duplex examination is what you need to do to confirm. Now, this classification is always put up everywhere in any venous meeting. You probably see a lot of it around. Have you all seen this before? So it's basically more important in research, I guess, in terms of trying to work out, a proper way of classifying venous disease. So there's the clinical signs, the etiologic, the anatomical, and the pathophysiological dysfunctions. So they go by class 1 to 6. Anything class 2 and below is considered to be uncomplicated. Anything class 3 and above would be considered to be complicated. So you've got the edema in class 3, the skin changes, so the lipodermatosclerosis. For class 4, you have in class 5 anyone with a healed ulcer, and of course class 6 is the most severe with current ulceration. So how do we decide on what treatment to offer patients? So that's the, I guess, most difficult thing to do nowadays because there's so many different treatments available. I like to think that you have uncomplicated varicose veins and complicated varicose veins. So anyone who has varicose veins that presents to me, I get them to have a duplex scan first. So that will identify whether they've got any great saphenous or deep system problems, and that will separate them into the 2 categories. So those with uncomplicated veins, everything else is fine in the truncal or axial system, and they've just got the reticular veins. So most of these patients are normally seeking treatment for cosmetic sort of reasons. Although it's considered to be cosmetic, but most of the time they do have aching legs, they do have sweating legs, and a lot of them, I guess psychologically, they still also suffer from that because they cannot wear the clothes that they want to wear or the shorts or the skirts that they would like to wear. So reflux or reverse flow in the saphenous system must be identified in order to achieve successful outcomes. And obstruction or incompetent deep venous system is a contraindication for superficial venous ablation. So what are the options here? Around 70% of veins are still being stripped in Australia. Major reason is because it's not offered in the public hospital. I guess the minimally invasive treatment is only offered privately. However, there's no single treatment that will help everybody, so we need to tailor them to each individual person. I think that all varicose veins treatments should be done under local anesthetic with a walk-in and walk-out procedure, and I think 90% of patients can probably achieve that. So the expected benefits and the risk of each treatment option needs to be discussed with the patient because a lot of them actually have new varicose veins that may develop after treatment. So it doesn't mean that the procedure hasn't been successful because new varicose veins do develop, and a lot of them will actually need more than 1 session of treatment, so it's not just come in, have the vein stripped, and then leave, because most of the time they'll have other tributaries or other things that needs to be addressed. And there's a chance of recurrence after treatment for varicose veins, especially if they've had a previous episode before. So we all know about compression as a treatment option. So that is, I'll just put up that slide, but I'll talk to you about it a bit later on about compression. So class 2 graduated compression, there's a lot of different brands of stockings that's available in the market, very expensive, they're made out of very good material, obviously that's why. So the minimally invasive options that we talked about is the next step. So the heat treatment is what I like to call it as. The endothermal ablations, basically, either endovenous lasers or radiofrequency. So these two have been around in Australia for more than 10, 15 years, actually being used in a lot of centres. The other one I wanted to touch on is the Venous. That's not available in Australia yet, I don't think. There might be little niches of people using that, so that's the super glue. It involves no heat, and it's only one local anesthetic injection. And then foam sclerotherapy, which I think most of you have heard or used or know about. So Venous radiofrequency ablation, that's, I think, the best heat treatment currently. The reason I say that is because you can treat patients in a short period of time. They have very little bruising. They're very comfortable. The patients that I've treated have gone back to work either the same day or the next day. So that's very, hardly any time off work at all. Here you can see a picture of that cannulation just below the knee, puncturing with the ultrasound. So anyone who wants to do this needs to be very proficient at using the ultrasound. That's one of the prerequisites. So how does it work? The catheter is inserted into the vein. Then it turns on this generator for 20 seconds. It heats up the collagen in the vein wall and it seals the vein. The catheter is then redrawn, sealing 7 centimeters at a time. Basically, it goes all the way up. We pull it back under ultrasound guidance, and I can actually see everything that's occurring at the time, especially when the heat is turned on. And you can see the vein actually being sealed off as the catheter is pulled back. I say radiofrequency is better because with laser, you need to get the laser set up, laser safety, laser glasses, that's a bit more complex compared to radiofrequency. So that's the machine. There's been many different wavelengths that has been used from 890 to 1470. 1470 is now currently supposed to be the best wavelength because it's similar to the wavelength of water. So this is the laser safety glasses that needs to be put on. Pretty much the same sort of thing with radiofrequency. So a catheter is placed into the great saphenous under ultrasound guidance as well. There's one thing I didn't mention about the radiofrequency before. So we need to inject local anesthetic tumescence all the way down. It acts as a heat sink because it's going to heat up the vein, and the saphenous nerve runs very close to the vein. So to avoid injury to that, and also to avoid burns on the skin. This is a video of the EVLT. Gold standard in the US. This has been since 2011. It was published in the JVS. We know that for the care of patients with varicose veins and associated chronic venous disease, it has been shown that the guideline is a strong recommendation to offer endovenous thermal ablation, whether it's RFA or EVLT. And it's moderate quality evidence that has been shown. And foam sclerotherapy as well has come up with a strong guideline. Grade of recommendation there. Now, this is going to be interesting because the treatment of incompetent GSV High ligation is only a grade 2 recommendation, so that's weak. So it's come down. Patients should not be stripped, basically, if they have any incompetent veins. I'll show you another thing, NICE guidelines. This is in 2013. You all know the NICE guidelines. Everybody knows the NICE guidelines. So in the UK, for people who have confirmed varicose veins and truncal reflux, offer endothermal ablation first. Now this is quite surprising for it to be actually published on the NICE guidelines. So if endothermal ablation is unsuitable, offer ultrasound guided home. And if that's unsuitable, then offer surgery. So surgery is actually now way down the line. So that's another point, that if there's incompetent associated tributaries, we should treat all of that at the same time. And the other thing that came up from that guideline is do not offer compression to treat varicose veins unless interventional treatment is unsuitable. In that sense, it means elderly patients, people who are not going to be able to tolerate treatment for one reason or another, whether they're pregnancy and breastfeeding would be contraindications to treatment at that time. So in the past, you have to go for general anesthetic, you have to have it stripped, long recovery periods, probably 2 to 3 weeks off work with a huge bruising leg. That's what everybody had. But now we've got all these, fantastic treatments available to people, and we can heal ulcers, we can treat, swelling. I mean, I'm not saying that we can treat everyone with swelling. It's quite difficult. But this is a very good meta-analysis that was done, greater than 10,000 patients, and it showed that, it doesn't come up very nicely on this, but Endovenous laser had a 94% efficacy. So that's very, very high, because surgery only had 78. You can't really see that.
You're saying it's not in the public sector, though?
Exactly what I was going to ask.
I'll give you a little secret. Alfred actually just started. And Monash as well, actually. So, the government is slowly coming to it because the item numbers are there now. So it didn't used to be. It was only recent. So we are strongly advocating for the patient. So we don't want them to have any of these stripping anymore. It's better for them to have this. Less costly, it's definitely less costly. They're not off work for 2 weeks. They go back to work immediately. They come into hospital. They don't even need to be in hospital. They come into the rooms, they leave. They walk in, they walk out, and then they drive home. It's fantastic. You should come and have a look at one.
All these thousands and thousands of people all got to front up to public hospitals and get
Well, that's the thing. I mean, once the government gives good rebates for it, especially people with venous ulcers, I think they should be treated. They should be the first step in the door, definitely. That's what we need to think about, like treatments for these people who can't actually access the system. So these are pictures not actually from my treatment, but from my colleagues. So you can see it's pretty good. That segment that's all disappeared, this is just with laser. Can you see, does it come up well, or should we dim the lights? And that's the same thing. This is with foreign. You can see some of these little stains there left on the foreign. But it's still pretty, I think it's excellent. And this is actually only a week after. You don't need to wait for long periods of time, as long as you can put up with wearing compression stockings after the treatment. So that's one of the things that you have to be able to do. You have to be able to mobilize. So we have to get everyone walking 30 minutes a day for 2 weeks. So that's more incentive to keep people healthy.
So how long do you use compression stockings after each of
For 2 weeks.
2 weeks.
Yes, it helps to seal the veins, basically, and it prevents recurrence. So the advantages are long, and just continues on and on. I've just listed a few. So again, short waiting times, walk in, walk out, no hospitalization, no general anesthetic, no time off work, no time away from family. It's very safe. There's no stitches. There's no scars. Well, there's a scar, a little scar where the catheter goes in. It's not very costly. You can talk to me about the cost. People can continue on with normal daily activities without having to stop anything, and sometimes people don't even need any pain relief, but otherwise Panadol and Nurofen would do. And there's a less chance of DVT because you mobilize as soon as you finish with the procedure.
Joy, how long does the procedure take? Say
Depends, because the most difficult thing is actually to get into the vein. If the vein is very big, 30 minutes and you're out. If it's a very small vein, you can have challenges to try to get into that vein. It can be anything from an hour to an hour and a half. But it shouldn't be more than that. You walk in, sit down for a bit, and then they leave. So it's fantastic. Now the next minimally invasive treatment here is the ultrasound-guided sclerotherapy. So this is how we do it with foam. Foam is known to displace blood, so that's why we use the foam. And there's two agents that it's used. So there's STS and polydocanol that's been approved by the FDA. Some people use hypertonic saline, and that's only used in people who have allergies, a lot of allergies, for allergic reaction to STS or polydocanol. So this has been foamed. You can see a little slight sort of appearance here. You can see a bit of darker sort of pigmentation here. So the pigmentation normally goes away. It takes a bit of time, but it does go away. Some people have it for up to 12 months, so that's quite, but I say to them, you don't have to put up with having a cut in the groin, scars in the legs, bruising, a little bit of that. It's tolerable. Most people tolerate it, and they're quite happy. These are little spider veins. You've got the reticular veins underneath here, the spider veins up here. Again, with the injections, you can see that's come up quite nicely. And this is the method of injection with a small 30-gauge needle. You just inject basically liquid sclerosant in there. I'll just go through the sclerosants very briefly. Do we have time? 5 minutes. It's done today. So the most commonly used, I've mentioned before, and these two, STS and polydocanol, or otherwise known as ethoxysclerol, polydocanol. So this is actually an anesthetic agent as well. So that's why it's very good. I use polydocanol. They don't feel anything except for the little, sting at the start when the needle goes in. But once that's done, they don't feel anything at all. Very low rates of allergic reaction and anaphylaxis for ethoxysclerol, polydocanol, and it was FDA approved in 2010. So the potential complications of UGS, there's quite a few here listed, which I've mentioned some of it before. Hyperpigmentation, you can get a bit of edema after the injection. This matting, telangiectatic matting, appears because new vein starts to form around where we've occluded. Most of that actually goes away after the vein finds the right channels to go up. So they take a little bit of time, but it does happen. It does go away. If you inject wrongly, you get blisters. So if they have a connection with an artery, so if you accidentally inject right next to the vein where there's an artery, you may get a blister and ulcer formation. Very common, you might get superficial thrombophlebitis, that's easily treatable. Allergic reaction I mentioned before. There's only a couple of cases that's been reported of PE and stroke. There's 9 cases that's been reported worldwide of having a stroke. And these are people who use large amounts of foam, greater than 50 mils. Only use 12 mils. And people with patent foraminal or large ASDs, you have to watch out for these people. I'm near the end. I put this ovarian vein incompetence up because I think it's one of these diseases that are not diagnosed enough, and especially in people who have recurrent varicose veins. Now, ovarian vein incompetence can be treated quite nicely now. Here is the catheter that goes into the ovarian vein. You can see the pelvic veins filling. I put some coils in there, and you can see that the vein, after being coiled, is actually not filling anymore. Patients with this treatment actually go away, then they come back for more injections on the legs, and then they have a less or lower risk of recurrence. So we've got to treat the feeding vessels first, anything proximally and come distally. So treat the truncal veins, the axial veins if they're incompetent, and then come down to the little ones. And you've talked about ulcers, or basically had a little bit of touch on that. Now I put this slide up because I quite like treating people with ulcers, contrary to what you may think, because it's quite satisfying to see them having, they come back and everything's healed up. It's very satisfying. And someone who has an ulcer like this can actually be treated with laser. The stab wound is actually above the ulcerated area, so it's just below the knee. They have a very small cut. They don't have to put up with big wounds that they have to heal up from. And with compression, of course, with the assistance of compression, the ulcer heals up. So can you prevent varicose veins? I guess that's what a lot of people want to know. No, because they're hereditary, you can't prevent them. While exercise is generally a good thing for the vascular system, it doesn't prevent or help visible or hidden veins. So prolonged activity, anyone sitting or standing, predisposes you to developing varicose veins. Now, support stockings, they should not be recommended as treatment. While they can improve the symptoms, they have no effect when you take them off. And finally, just a little slide about what to do, I guess, referral to vascular service. I'm sure this is a very basic sort of list. Anyone with venous ulcers, symptomatic varicose veins, lower limb skin changes. Thank you.
Sorry.